Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthetics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hands.org/dental-training. For future inquiries, contact Facilitator.
We have the honor and privilege to have Dr. Matthew Galli. Dr. Matthew Galli is a third-year graduate resident at in the Department of Periodontics and Oral Medicine at the University of Michigan School of Dentistry. He completed his DDS at the University of Toronto in 2019, where he started his own charity initiative aimed at providing gifts for underprivileged teenagers during the holiday season. He was also president of a chapter of the dental fraternity in his senior year. During his BDS and the DDS, he conducted research focused on macrophage polarization and osteoclastogenesis in the context of periodontitis, and has published numerous papers in peer-reviewed journals on these topics, in addition to periodontal clinical research conducted during his residency. Dr. Galli, I interact with a lot of people, and I know that you are going to the top. In a few years' time, I see you guys. You're on your way there. Well, thank you for giving your time today to present on Dental Webinar Series.
I'm really excited to be here. As Uvoh said, my name is Matthew Galli. The title of this lecture is Surgical Implant Placement, Foundational Principles for Decision Making. So without further ado, let's get into it. So just to give you some background, I'm born in Canada. My family lives in Mississauga, which is in the province of Ontario. Here you can see a picture of me and my family when we were recently on vacation in Florida. There's a picture of my family's dog. His name is Cody. And here's a picture of me and my co-residents. And I just also wanted to mention that my dad is born in Cairo, Egypt, so I have some origins from Africa as well. So the outline for today's presentation is as follows. We're going to start by talking about some guiding principles and foundational concepts regarding treatment planning, then implant positioning, the prosthetic-biologic connection, periimplantitis, and lastly, I'm going to go through some cases step by step and just demonstrate the concepts that we discussed. So let's begin with treatment planning. What are the foundational principles that should guide you in your decision making? So really the aim of dental implant therapy in general is to support a functional and aesthetic prosthesis. You want to minimize the number of surgical procedures and morbidity of the patient wherever possible. You also want to reestablish and maintain the peri-implant hard and soft tissue dimensions over time. Talk about why this is important later on. You also want to have acceptable cost and treatment time. And so the number one goal can really be summarized from survival to sustainability. What are the overlap factors for therapeutic success? Hard and soft tissues, ideal positioning, maintenance and education of the patient, and also having a cleanable and functional and aesthetic prosthesis. So I think now that we've talked about implant success, it's important to realize the different causes of failure. And so the different causes of failure are as follows: periimplantitis, soft tissue dehiscences and recession. Although the implant may be in survival with such an occurrence, these are considered aesthetic failures mostly. Loss of osseointegration and fracture, where the two most frequent causes of failure are periimplantitis and soft tissue dehiscences, both occurring in the 20 to 25% range. Whereas loss of osseointegration is pretty rare and fracture is pretty rare as well. And so when you think about treatment planning with dental implant therapy, I want you to divide it into three phases, where phase one is disease control. Firstly, it's important to realize that you have to perform decay removal and restorations as needed. Extraction of hopeless teeth is also important. And in the consideration here is that if you're planning to place an implant in the future, you should consider conducting alveolar ridge preservation or augmentation of the ridge. And so here's an example where I extracted a hopeless tooth. The buccal plate was compromised, so I tunneled under the buccal tissues, inserted a collagen membrane. I also tunneled in the palatal area, inserted some bone graft into the socket, and closed with some sutures over top. In addition, if patients have periodontal disease, active disease needs to be managed. An important aspect of this is also providing oral hygiene instructions. We can see here in the maxillary anterior region, this patient initially presented with some deeper probing depths at some of the teeth. And he also had some BOP with some mobility. And so what does this involve? First, conducting scaling and root planing, non-surgical therapy, reevaluating the case 4 to 6 weeks later, and determining if there's a need for further corrective therapy. We can see here that upon the completion of non-surgical therapy, the deep probing depths were still present. So how did I treat this? So I performed an open flap debridement, and I also performed some occlusal adjustment and splinting of lateral incisor as there was fremitus and occlusal trauma there. So all these are important aspects of managing the disease. In addition, systemic diseases are also important to consider, especially smoking cessation and glycemic control for diabetics. Now we're talking about the second phase, rehabilitation of edentulous ridges. So we can see here a case where I placed a couple implants. I'm going to show again this case later on in relation to the need for GBR. So implant site development is an important consideration in terms of rehabilitation with implant therapy. There's kind of two main components to this, the hard and the soft tissues. With hard tissues, the options we have available are alveolar ridge preservation, ridge augmentation, which can take place staged or simultaneous, where staged refers to when you're doing ridge augmentation and then you're placing the implant at a later time point, orthodontic extrusion of the tooth prior to extraction to help increase the bone levels, ridge expansion, and ridge reduction. Whereas for soft tissue, the options we have available are connective tissue grafting. This is mostly done to increase tissue thickness or to treat recessions. Free gingival grafting, which is mostly done to increase the keratinized tissue width. Apically positioned flap is another important option that we have to increase keratinized tissue width. And pedicle flaps is another option where we're basically boring tissue from adjacent sites. So an important concept to understand is the peri-implant phenotype. And this is composed of the keratinized tissue mucosal width, mucosal thickness, the supracrestal tissue height, and the peri-implant bone thickness. And so basically you want to have 2 millimeters of buccal bone thickness, keratinized tissue width, and mucosal thickness around your implants in order to have long-term stability. So let's take a look at some soft tissue management around implants. This is a case where I performed free gingival grafting at the time of stage 2. You can see here that when it was ready for implant uncovery, that the buccal mucosa is thin and there's a lack of keratinized gingiva. So how did I handle this? So I harvested a free gingival graft from the palate, sutured it in place over a periosteal recipient bed. And 2 weeks later, it looked like this. You can see that I gained adequate amount of keratinized tissue, also simultaneously increasing the tissue thickness. And 6 months later, we can see a decent result with the keratinized tissue width increased with the free gingival grafting procedure. Here's an example of an apically positioned flap. So for this procedure, you're going to see that I make a palatally biased incision at the time of implant uncovery, and I basically borrow tissue from the palate and bring it over towards the buccal. So doing this type of procedure can circumvent the need for doing a free gingival grafting procedure, and basically it can help to reduce the morbidity in terms of for the patient. 2 weeks later, you can see that overall things are looking good. I was able to increase the keratinized tissue width. And 1 month later, the results are also looking nice. So when is GBR needed? I want you to look at this case and think. Remember I was describing before. in this case, there's 2 millimeters of buccal bone thickness, so no GBR would be needed. But for a case like this, I mean, it's obvious if the implant threads are exposed, you're going to need to do GBR. But in a case like this, the buccal bone is pretty thin, especially at the coronal aspect with slight thread exposure. And so GBR would be needed in this case. So what does the literature say? Well, based upon the residual facial bone thickness, you can see from a couple prominent studies in the literature by Spray et al. In 2000 and Monhe, that basically there's a concept called the critical bone thickness. And so this is the amount of buccal bone that's needed in order to prevent future bone loss around the implant. And so really the aim is to avoid exposure of the rough surface to microbial contamination over time. And by having sufficient bone thickness, you can protect the bone over time. So this is an important concept that I want you to understand. So guided bone regeneration, it can be performed simultaneous with implant placement, as was done in this case, where basically I placed some allograft over the exposed threads of the implant, placed a collagen membrane, and I secured the collagen membrane with resorbable sutures engaging the periosteum on the buccal and the palatal flap. It can also be performed in a staged approach. In this case, which is planned for a mandibular overdenture, the patient has a hopeless dentition in the mandible, and he has a complete upper denture. And so for the time being, I'm maintaining the lower teeth, which will eventually be extracted because it'll give the patient some chewing function. But eventually what I want to have for this patient is to have a lower overdenture with 2 anterior implants. And so we can see in the second picture on the upper right-hand side, the bone thickness is very thin. And so in order to prepare for the overdenture and the implant placement, I decided to augment the ridge and come back and place the implants later after healing. The third phase, which is very important, is maintenance and patient education. And so you should really tailor maintenance. It's not a one-size-fits-all approach. You have to decide, is the patient at high risk or low risk for oral diseases? High-risk patients are characterized by having poor oral hygiene, previous history of caries and periodontal disease, smoking, and diabetics. For these patients, you want to have a tighter interval, a tighter recall frequency, bringing them in more frequently for education and maintenance purposes. Lower risk patients have good oral hygiene, a minimal history of caries and periodontal disease, and are non-smokers and normal glycemic. For these patients, you can allow them to come about every 6 to 12 months. So let's go over the timeline of dental implant therapy for a 2-stage approach. Beginning with the extraction, and this is, by the way, for delayed implant placement. So beginning with the extraction, you're going to wait 3 to 4 months, then implant placement, and then you're going to wait another 3 to 4 months, unless GBR was conducted, in which case you'll wait 6 months. Then you place the healing abutment at the time of uncovery. Then 3 or 4 weeks later, after the soft tissue is healed, the process of crown fabrication and crown delivery can begin. So when do you perform 2-stage approach with submerged healing? So for this approach, you're going to place a cover screw, and it's usually chosen if simultaneous GBR and or poor primary stability is present. A 1-stage approach can be done if there's adequate primary stability. In this case, you're going to see that it'll help to save the patient overall in time in terms of the overall treatment. So beginning with the extraction, you're going to wait 3 or 4 months, perform implant placement, wait another 3 or 4 months, and then the process of crown fabrication and crown delivery can begin. So as I mentioned previously, I was talking about the concept of primary stability. Primary stability is really the amount of mechanical interlock that is attained at the time of implant placement. It can be measured with a torque wrench and is usually considered adequate between the range of 25 to 45 Newton centimeters. This is really dictated by the macro design, bone density, and osteotomy preparation. Secondary stability speaks to deposition of new bone and the development of osseointegration. And this is dictated by the micro, and nano design of the implant and is measured with bone to implant contact. So this chart here, I got from a study by Raghavendra. And you can see that in about the 2 to 4 week period, there's a drop in primary and secondary stability. So this is really at the time point when implants are at their most vulnerable, if loaded, to failure. So how does one choose the correct implant diameter? I'm going to use the Zimmer TSV system with the aesthetic implant as well included to kind of discuss how you would choose the correct diameter for different sites in the mouth. So it's important to note that this implant system, specifically the TSV, has a 1 millimeter machined collar, and beneath this, there's a 1.5 millimeter MTX surface, which is roughened. Generally speaking, the 3.1 millimeter diameter implant with a 2.9 millimeter platform is ideal for maxillary lateral incisors and mandibular incisors, whereas you want to pick a 3.7 or 4.1 millimeter diameter for maxillary central incisors, or both in the maxilla and mandible for premolars and canines. The 4.7 and 6 millimeter diameter implant should be reserved for molar sites. But it also really depends on the situation in terms of the mesiodistal spacing. As we're going to talk about later, you really have to begin with the end in mind. And you have to picture the future emergence profile of the restoration when choosing the implant diameter as having a large mismatch between the implant diameter and the crown width can produce an unfavorable emergence profile hindering access for oral hygiene and diagnosis with probing. So here is a couple of pictures of Straumann's implant systems that they have available. And I want to talk a little bit about tissue level versus bone level. So you can see with the tissue level, they have a couple options available. The standard has a 2.8 millimeter polished collar, whereas the standard plus has a 1.8 millimeter polished collar. So you can see that in terms of the ideal placement for bone level implants, you really want to make sure that the roughened surface doesn't become exposed to microbial contamination over time. So these implants are usually placed equa or slightly subcrestal. And for tissue level implants, you want to place the interface between the polished collar and the rough surface, equicrestal or slightly subcrestal. So when do we choose a bone level versus a tissue level implant? So there's some important concepts to understand. For bone level implants, these are usually most ideal for anterior and aesthetic sites. This is primarily due to the fact that you have more prosthetic options for these implants. And these can also be utilized in cases of limited interocclusal distances because the absence of the polished collar, which needs to be maintained above the bone, allows you to basically treat these cases more effectively. Tissue level implants are ideal for posterior sites. You have to be aware that with tissue level implants, there's always the risk that if there's some recession, you can get exposure of the metal collar, which might compromise the aesthetic results. Tissue level implants are also ideal if there's adjacent teeth with bone loss. And this is because with the polished collar, it allows you not to have too tall of a crown. Having a crown that's very, very tall can basically lead to increased incidence of prosthetic complications such as screw loosening due to the fact that it generates a vertical cantilever effect. And there's some limited evidence in some studies that show that there's reduced marginal bone loss and periimplantitis around tissue level implants, but this evidence is generally pretty limited. In terms of oral surgery contraindications, important for treatment planning is to realize the medical history of the patient and how this can impact your future treatment outcomes. And basically, you want to do no harm to the patient and make sure that you're performing surgery in a safe manner. If a patient has had a recent myocardial infarction or stroke, you want to wait about 6 to 12 months to initiate the surgery for elective therapy. Also for valvular prosthetic surgery, 6 to 12 months. Immunosuppression, it's important to get basically a blood test done to see the white blood cell count and the neutrophil count, make sure that they're within normal ranges. And if there's hemostasis issues, for example, for warfarin, you want to maintain an INR of 3 or less. And platelets should be more than 50,000 per millimeter cubed. If patients are on new blood thinners, basically what you might want to ask the physician if there's the possibility of asking the patient to abstain from taking their blood thinners prior to the surgery, and they can restart taking it afterwards. Also, you want to avoid treating patients with active malignancies and before completion of skeletal growth. Skeletal growth is particularly important because if you treat patients when they're too young before the completion of their skeletal growth, you can have the risk of infraocclusion of the prosthesis. So let's go through some factors regarding optimal implant positioning. Really, what I want to stress is that the ideal position is prosthetically driven and respects biology. In terms of apical coronal positioning, the reference points that you have are the CEJs of the adjacent teeth and the crestal bone. And you also want to maintain a safety distance from anatomic structures such as mental nerve, inferior alveolar nerve canal, lingual concavities. You want to stay about 2 millimeters away from these areas. The lingual concavities become particularly important in the posterior mandible, and you want to make sure you always palpate the patient in these areas to see if they're present. If there's a torus, this can be a little bit misleading because apical to the torus, there might be a concavity which might be masked by the presence of a mandibular torus. And so we can see here a chart that kind of summarizes the different factors you should take into account with the apical coronal positioning. Basically, if you're using the CJ as a reference point, for non-aesthetic areas, you want to maintain about an apical coronal position that allows for 1.5 to 3 millimeters apical to the adjacent CJ. And for highly aesthetic areas, there should be about 3 to 4 millimeters apical to the adjacent CJ. And this is to have adequate running room for development of a functional and aesthetic prosthesis. In terms of mesiodistal distancing, the safety distance is not always equal to the ideal distance that you need for development of an emergence profile. If we're talking about safety distances, in terms of not compromising future outcomes, you want to have about 1.5 millimeters away from adjacent teeth and 3 to 4 millimeters between adjacent implants. For single implants, you want them to be aligned with the midline of the future prosthesis and centered between adjacent roots. And for multiple implants, you want them to be parallel and aligned with the opposing arch. For buccal lingual positioning, you can see here that for an anterior implant, if you're going for a screw retained prosthesis, to prevent the screw access opening from being in a non-aesthetic area, you want to aim for the cingulum position. For the posterior areas, you want to aim for the central axis of the implant to be aligned with the central groove of the future prosthesis. Digital planning can help you to visualize this. So here's the chart that also summarizes what I just talked about. So how do you obtain the ideal position? This is an important question. In addition to performing a clinical exam, where during the clinical exam, you should look at the mesiodistal spacing and plan for the correct implant diameter. You should also look at radiographic imaging, which is a very important part of implant treatment planning. So the different options you have available are two-dimensional radiographs, including panoramic radiographs, periapical radiographs, and bite wings, as well as three-dimensional radiography, which can really help with implant treatment planning by being able to visualize basically the bone dimensions in 3 dimensions. If you don't have CBCT available, one option that you can use for guided implant surgery is you can take an impression of the patient, pour up this impression into a stone model, basically drill a hole into the stone model in the ideal position, and you want to take reference from 2D radiographs when you do this to make sure that you're aligned with the adjacent tooth root. And then you can put a pin, cure this into place with some monomer, and then you can use a triad or another type of polymer, and you can construct the surgical guide with a sleeve in place that can allow you to obtain an ideal position during placement. Also relevant to talk about is fully guided surgery. And basically what this involves is superimposition of intraoral scanning data with CBCT 3D radiographic data, allowing you to generate a virtual guide. You will use this information, plug it into a 3D printer, and print out a guide that you can insert some sleeves into that will basically guide your implant placement through the sleeves and your osteotomy preparation through the sleeves. So what's the difference between freehand drilling and guided surgery? Well, with freehand drilling, you have an unlimited range of drilling trajectories. So you have to have more experience in performing freehand drilling. And if you're just starting out, try to make a guide for your first few cases, as this can really help you to visualize the case in your head before you begin. And later on, you can move on to freehand drilling. Guided surgery can help because it constrains the drill to a planned trajectory. Here's a case where I performed freehand placement. And you can see that I'm trying to follow the alignment with the adjacent tooth root. In addition, it's important to realize that advancements in ridge augmentation and GBR have allowed us to achieve prosthetically driven implant placement. So you want to place the implant not where the bone is, but you want to place it keeping in mind what is ideal for the future prosthesis in order to generate a functional and aesthetic and cleanable future prosthesis. And you want to place the implant in relation to the plan for the prosthesis. This is really at the heart of prosthetically driven placement. And so guided bone regeneration can allow you to place implants in compromised ridges because you're able to augment the width of the ridge or the height of the ridge. So let's talk a little bit more about prosthetically driven placement and also how the prosthesis is intimately connected with the biology around the implant. So in the past, we were in the era of dentures and bridges. Moving forward, we've now entered the era of implantology, where more options are available to us as clinicians to rehabilitate edentulous regions. So basically, in the past, we had to make choices based upon the available abutments, and this basically dictated the prosthetic design. Then moving forward, when we entered the era of implantology, at first, treatment planning philosophies were primarily bone-driven, so placing the implant where the bone is, not giving as much consideration as necessary to the future prosthesis. Then moving forward, after more long-term outcomes were realized in the literature, it was really discovered that what's important is placing the implant, but having an understanding of the planning for the future prosthesis and placing the implant in relation to that. And advancements in guided bone regeneration as well as guided surgery can help with this. So this is kind of a nice quotation from somebody who I really respect, Stephen Covey. He's a great author. He's wrote the 7 Habits of Highly Effective People. You want to begin with the end in mind. So this is a paper that we recently submitted for publication. And really what I want to stress over the next few slides is that there's a really significant and substantial connection between the prosthesis and the stability of the peri-implant's soft and hard tissues over time, which has to be respected in order to promote an environment for long-term success. Why is this important? Well, the prosthetic design can influence the stability of the peri-implant marginal bone levels, susceptibility to prosthetic and biologic complications. For example, for a prosthetic complication such as screw loosening, or biologic complications such as periodontitis, as well as access for peri-implant maintenance, hygiene, and diagnostics such as periodontal probing around the implant. So we can see here on the left, we have an ideally contoured prosthesis. And for this prosthesis, it allows adequate access for probing and oral hygiene, versus on the right-hand side, you can see a prosthesis that has a buccally over-contoured surface, which inhibits access for oral hygiene as well as probing. So this study by Serino found that 48% of implants that presented with peri-implantitis did not have access for oral hygiene. So you can really see how important having proper oral hygiene is for maintaining the stability and health of the implants over time. Here's another study by Ravita and colleagues, where basically they compared 3 different scenarios: 3 single implants with non-splinted crowns, 2 implants with a bridge with a pontic in between, so a 3-unit bridge, and 3 implants with splinted crowns. And basically what they found is as follows. The first option had increased costs because you're placing 3 implants as opposed to 2, and an increased risk of prosthetic complications as the implants were non-splinted. The second option has decreased costs because you're only placing 2 implants, decreased risk of prosthetic complications, and relatively low risk of peri-implantitis as well. Whereas the third option had increased costs and really hindered access for oral hygiene. One of the disadvantages of splinting implants is that although you may have less incidence of prosthetic complications, you also severely limit the access for oral hygiene if the prosthesis is over-contoured. And you can see here what they found was that the middle splinted implant had the highest incidence of peri-implantitis. And this is primarily due to lack of access for oral hygiene at this implant. So another important concept to understand is the emergence angle of the implant, or the emergence angle of the prosthesis. And so this is really measured taking into account the long axis of the implant and the angle between this and the abutment surface, as well as the crown surface. And so A couple important studies done in the literature on this topic are Yi et al. And Catafucci et al. And basically what they found was that for bone level implants, having an emergence angle greater than 30 degrees, as well as a convex prosthesis, was associated with a higher prevalence and risk of periimplantitis. Again, it's a question of access for oral hygiene. If you have a bulky over-contoured prosthesis, it limits the access for oral hygiene. One important thing to realize is that placement of a deeper placement of the implant can provide more running room, which is the vertical distance, allowing for development of a more natural emergence angle. Versus shallower placement, you don't have as much vertical distance to do this, and so you'll oftentimes, if there's a large mesiodistal distance that you need to accommodate for the crown, it'll end up with an over-contoured prosthesis. Implant diameter is also important to take into account for this. Another thing I'd like to mention is that if you have a larger than ideal mesiodistal distance, consider placing the implant distally and then having a mesial cantilever. This can help with increasing the access for oral hygiene and having a more natural emergence profile. So this type of altered prosthetic design was explored by Tuna et al. In a study they published in COIR. And what they found was that with this distal placement versus placing the implant centrally, you can have increased biofilm removal with different oral hygiene methods such as superfloss, interproximal brushes, and dental floss. So as I was talking about earlier, mismatch between the implant diameter and the mesiodistal spacing, it can result in a poorly contoured prosthesis. Deeper placement can compensate for this. The platform switching concept is also important to discuss. Platform switching basically is defined as a deliberate mismatch between the implant diameter and the diameter of the abutment. And this can allow for increased soft tissue thickness and movement of the interface away from the crestal bone. So you can think that there's always going to be a certain degree of micro leakage around interfaces with restorations and implants. And so by moving this away from the crestal bone, you can move this micro leakage away and basically help to reduce the risk of chronic inflammation and hopefully to preserve the bone levels over time. So now let's talk a little bit about periimplantitis. So periimplantitis was most recently defined in the World Workshop on the Classification of Periodontal and Peri-Implant Diseases. These papers were published in 2018. And there's two definitions based upon if you have baseline data present or if baseline data is absent. So if baseline data is present, the definition of periimplantitis is basically when you have a bone loss beyond initial remodeling in the presence of bleeding on probing and suppuration and an increased probing depth compared to baseline. But really the most important variable is, has there been bone loss beyond initial remodeling? And so remodeling can be thought to initiate at the time of abutment placement. And basically, if the baseline data is absent, then we're going to have some numbers to rely on, and probing depth greater than or equal to 6 millimeters and bone loss greater than or equal to 3 millimeters, also in the presence of BOP and or suppuration. But it's important to realize that the most important variable for differentiating periimplantitis from peri-implant mucositis is the presence of progressive bone loss over time. These are the tools that we have available for diagnosis of periimplantitis. So a clinical evaluation, including periodontal probing, evaluating the soft tissues to see if there's erythema, also looking at bleeding on probing, radiography, and then you have to have the knowledge to use these and putting it all together to come up with the proper diagnosis and differentiating periimplantitis from initial remodeling. So what does periimplantitis look like? Here we can see a few different examples that I'm going to show. You can see that there's been a peri-implant soft tissue dehiscence on the buccal aspect with thread exposure, significant bone loss of about 6 millimeters on the mesio and distal aspects of the implant. Here we can see a similar scenario with exposure of the roughened surfaces. And here, as I mentioned, you can see that the middle implant has experienced significantly more bone loss than the mesial and distal implants, but the mesial implant also has significant bone loss. And this is likely due, as I mentioned previously, to the fact that it's just harder to clean that implant that's in the middle of a splinted prosthesis. Here's another example. I want you to look at this scenario. Look at this prosthesis that's supporting the two implants. And I want you to think, is this a cleansable scenario for the patient? How is this going to affect the supporting tissues over time? Well, looking at this radiographs, you can see what the result is. So in this scenario, you can see that the implants were placed too shallow and were then restored with a prosthesis that is not cleansable. And you can see that, especially the distal implant, that it suffered from a severe periimplantitis as a result of this. And so what are the factors that are important to consider when considering the risk of a patient with peri-implant disease? Well, there's a great study by Heitz Mayfield, Heitz and Lang, where they basically create this spider diagram that can allow you to assess patients and their risk for future peri-implant disease. And so what are the different variables that are important here? The periodontal history of the patient. If a patient has a previous history of periodontitis, they're going to be at higher risk. The percentage of sites with bleeding on probing. The percentage of sites, including natural teeth, with probing depths greater than or equal to 5 millimeters. The bone loss of the patient divided by the age. Again, this all relates to the periodontal history of the patient. The periosusceptibility. The maintenance frequency. Is the patient compliant with maintenance or are they not compliant with maintenance? The distance between the radiographic margin and the bone. So this is a question of biologic width. Essentially, you have to take into account that you want to have the radiographic margin to be a safe distance away from the bone. And if you need to have a taller abutment, you should place it, because if this margin is too close to the bone, it creates a source of microleakage that's in proximity to the bone, triggering chronic inflammation. And eventually that can result in exposure of threads and rough surface to microbial contamination, which can speed up the progression of peri-implant disease. And as I was discussing, is the prosthesis cleansable or is it not cleansable? This is really important to consider when fabricating prostheses. In addition, screw retained is usually going to be ideal because there's always the risk of cement excess remaining subgingivally, which can contribute towards the progression of peri-implant disease. So what are the established risk factors for peri-implantitis? Well, a recent article by Schwartz et al. Published in JCP summarizes this. Really, the most important risk factors are going to be the history of the periodontal disease of the patient, and this can include untreated or previous periodontal disease, insufficient plaque control. So how is the patient's oral hygiene? If it's poor and there's a poor prosthetic design and they're non-compliant with maintenance, they're going to be at higher risk for peri-implant disease. Another way to think about it is you want to avoid exposure of the implant rough surface to microbial contamination. And so you really have to be understanding all the things that we talked about before so that you can avoid this when you're placing your implants. What are some of the different variables that can cause this? Well, if you place the implant too buccal, you're going to compromise the amount of adjacent buccal, the amount of available buccal bone. If there's a lack of buccal bone, then this is susceptible to resorption over time. And in addition, peri-implantitis itself can cause exposure of the implant rough surfaces over time due to bone loss. So let's put it all together in some cases. So I'm going to show 3 pretty different cases, and I kind of want to go step by step through what I did and just describe it to you. And then at the end, we can go through some questions, and I want to address anything that you're curious about. So we can see here a scenario where there's a non-restorable hopeless tooth adjacent to an edentulous site. So I planned for immediate implant site number 12 and delayed placement site number 13. This is a 52-year-old female patient. And so I conducted cone beam computed tomography for this patient. And even though you can see here that I did some digital planning on a program called Blue Sky, I didn't actually print a 3D guide, but even if you're not planning to print a 3D guide, sometimes it's still useful to do this digital planning as it can help you to visualize the implant position in your head prior to the surgery. So first I extracted the hopeless tooth. And you can see here that my incision design was as follows. Basically a mid-crestal incision, and then following around the contour of the molar. And then I placed the 2 implants. The implants that I chose here were 3.7 by 10 millimeter Zimmer TSV implants. And the drill sequence involved first using a round burr. The round burr is useful to use at first because you'll find that the other drills will have a tendency to bounce around and not to engage the bone unless you've created a channel for them to engage. So the round burr is useful for this. The next burr in the sequence is a 2.3 millimeter diameter burr. I went to 6 millimeters depth. And then at this point, it's useful to take an x-ray and just to gauge your positioning in relation to the adjacent tooth roots and in relation to the 2 adjacent implants for themselves. Then I took the 2.3 millimeter to 10 millimeters depth. Then I did a 2.8 millimeter drill diameter to 10 millimeters depth. And then I used the final drill. And so in the maxilla, oftentimes you don't have to use the final drill to depth. You can just use it at the coronal aspect because the maxilla has usually softer bone. And so by using the last drill only to half the depth, then you can basically increase the probability that you'll have a good primary stability during placement. So I placed the 2 implants. I grafted the gap around the immediate implant. I put a collagen tape over top. And I secured the buccal and palatal flaps in place using 6-0 polypropylene sutures. We can see here a radiograph at the time of placement. You can see that I followed the anatomy of the adjacent teeth to avoid basically getting too close to the roots, and also to make sure that in the future I have enough room for the development of a healthy and aesthetic and cleanable prosthesis with a natural emergence profile. So here's another case. This was a 46-year-old gentleman. Number 11 was extracted with alveolar ridge preservation in private practice 5 months prior to my implant procedure. And for this case, I performed simultaneous GBR, and you're going to see why in a second. But first, I want to discuss what the ultimate restorative plan is for this patient. Ultimately, they want to have a tooth and implant supported RPD. And you might ask, why didn't I place the implant in a different position? Why did we choose site number 11? Well, it's because the posterior sites had severe sinus pneumatization and the patient wanted to avoid sinus augmentation. So we chose site number 11 based upon this. So you can see here at the time of osteotomy preparation, there's a large buccal defect. So how did I handle this? Well, after placing the implant, and I'll just go through the drill sequence first. First starting with the round burr, then the 2.3 millimeter diameter burr. As I mentioned, I like to go to 6 millimeters depth at first, then 2.3 millimeters to 10, then 2.8 millimeters to 10, and then 3.4 millimeters to 10 millimeter depth, and I placed the implant. So you can see there was a lot of thread exposure. So first I harvested some autogenous bone from the adjacent sites. I'm using a bone scraper, and I placed this directly over the exposed threads of the implant. Then I placed an allograft over top. In this case, I used LifeNet Cortical. It's important when you're doing GBR that you want to over contour because the graft is going to resorb over time. So in order to have about 2 millimeters at the end of the day on the buccal aspect, you really need to compensate by over contouring. You're going to have to contour about 4 or 5 millimeters to get that. So I placed the allograft over top. I used a pericardium membrane draped over the grafted area, and I tucked it under the palatal flap. And I secured with 4-0 Vicryl. And here's a post-op radiograph. 2 weeks later, you can see that there wasn't an incision line opening, and the healing is looking nice. Now I want to show, this is the last case I want to show, delayed implants in the lower anterior mandible. So this is a 77-year-old female patient who presented with complete upper and lower dentures. She wasn't satisfied with the retention of the lower denture, and so I planned to place 2 anterior implants in the mandible to help with retention of this prosthesis and to help with limiting the movement of the prosthesis. So I did CBCT in this case, just to visualize the bone thickness and the bone dimensions. And you can see that the way that the bone is shaped, there's a knife edge bone topography on the coronal aspect, and this widens out apically. This is really, really common with overdenture cases. How do we handle this? Well, you do bone reduction. And what's the benefit of this? Well, as the mandible, as you progress apically in the mandible, usually it flares out. And so you gain more width by doing this. By reducing the ridge, you can gain more width for the implant. And also, it helps with increasing the restorative space. So in this case, about 5 millimeters of bone reduction was needed. So you can see how knife edge shaped that ridge is in that upper picture. So basically, how did I do this? I used a high-speed handpiece with a burr, and I reduced the ridge until I got sufficient width, and then I placed the implants. And here's a post-op radiograph. So really the takeaways that I want to give you guys are thoughtful planning is really key in terms of having long-term success and stability. You want to protect the bone. What can we do to protect the bone? You want to do GBR if it's needed. So if there's thin bone or implant thread exposure, you need to do GBR. You also want to basically take into account all the variables that I said previously and take into account that you want to maintain the hard and soft tissue dimensions over time. You want to fabricate a cleanable and aesthetic prosthesis. And you want to tailor maintenance and education to each patient. So always remember that an implant is a good replacement for a missing tooth, but not for a restorable tooth. So thanks for your attention. If you enjoyed today's presentation, feel free to follow me on Instagram. We're going to be posting some more cases. And let's get into some questions. So I'm going to look at the question and answer. So is Sendranata here? I'm reading your question right now. Can you hear me? So Sendranata asks, thank you for the presentation, doctor. My question is there any implant diameter and length selection guideline and related to bite force of each tooth and quality density of bone? So really, I want you to think about this in terms of the future prosthesis. So think about the available mesiodistal space and then plan for an implant diameter that will match with the crown size. So in terms of length, you can think that if you're going for a smaller diameter, you can compensate by going longer. So you want to think about the amount of surface area of the implant that's in contact with bone. So for a smaller diameter implant, ideally you're going to want to go a bit longer. And for a shorter implant, you can go a little bit wider. Those are kind of the important factors in terms of selection of the diameter and length. You also want to take into account the safety distance from adjacent structures. For example, the mental nerve, the inferior alveolar nerve canal, the lingual concavity that I was discussing. You want to stay about 2 millimeters from that, so that also has to be taken into account for length. For length in the posterior maxilla, you have a few different options. So in the posterior maxilla, you always have the option to perform sinus augmentation if there's an atrophic ridge in the vertical dimension. But alternatively, you can also consider placing a shorter implant. And so there's a couple options available for maxillary augmentation that can allow you to place a 10 millimeter, let's say a 10 millimeter implant. If the residual ridge height is very, very limited, you'll have to do a lateral window approach. And if it's moderately limited, you can do vertical augmentation, a vertical sinus bump. I hope that answers your question. Let me know if you still have anything that you're curious about and I can address it. And then I see from anonymous attendee, how relevant is crown to implant ratio and consequence to biologic and prosthetic complications? So this is a great question. So if you look in the literature, there's quite a few studies on this topic. And basically what they show is that regardless of the crown to implant ratio, it's not necessarily going to impact the marginal bone levels over time. It's not necessarily true that having a tall crown in relation to a short implant is going to cause you to have increased marginal bone loss. That's not the way I would think about it. A study that you can look at if you're curious about it, there was a couple done by the Michigan group, I believe with Revita al is one of them, and also Garacoa Pasmino has a study. I can send it to you later if you message me. But really what I want you to consider is the crown length. Irregardless of the implant length, having a tall crown can basically predispose towards prosthetic complications. I hope that answers your questions. Let me know if you're still curious about that.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator